What's a coronavirus and why should we care? How did it come about and what's it up to now? Our speaker became a science geek at age 7 when she briefly served as the experimental subject for her older brother's research on gravity. Well, after graduating Phi Beta Kappa with a degree in English, she went to medical school. 9 years and a general surgery residency later, her father's only question was, does this mean you're finally getting a job? After 5 years, she faced the economic reality of practicing general surgery in rural Central California, either stop accepting Medi-Cal patients or close her doors. She began working throughout the United States and internationally as a surgeon in underserved communities, including the Choctaw Nation in Tallahassee, Oklahoma. When a 2009 earthquake and tsunami devastated American Samoa, she did medical relief on the island nation for 3 months during the H1N1 pandemic. In 2010, she was elected to the California State Legislature. Finding politics too bloody, she became the surgeon on a Caribbean island near Haiti for 3 years, returning to the US in 2015. Retiring to the Mojave Desert, she now happily spends her time studying virology and immunology. She will tell us about queens and crowns, the story of bats and men, and the compelling story of mutations, stuff you cannot find on Facebook. So let's have a truly transmogrifying welcome for Dr. Linda Halderman.
Thanks, guys. What a kind thing. I appreciate the welcome. Today, I'll give you my outline. It'll give you some ideas I have to yap about, and then some ideas in case you decide my topics don't stimulate you. You can pick some other ones. Feel free to jot these down, and if you hear something you want to ask about, I think the question and answer part's a little more interesting than the me talking part. So what's a coronavirus? First of all, coronavirus is not specific to COVID-19. A coronavirus is part of a class of viruses. If you think about fruit, fruit is kind of like coronaviruses. It's just a classification. Under fruit, we would say there are Red Delicious and Honeycrisp and Granny Apple. And of all the different coronaviruses on the planet, we're interested mostly in only about 7 of them. The reason is, of all these many dozens of coronaviruses, only 7 of them are capable of infecting humans. At any given time, there are at least 3 dozen coronaviruses living in bats. They don't cause bats to become ill, and they don't have the ability to infect humans. But a couple of them are in fact different. And so let me show you why coronaviruses were called coronaviruses in the first place. Corona is a Latin for crown. Someone decided that Queen Elizabeth had these little things on her amazing diamond crown. And because of that, they said, okay, this virus shares something with the Queen of England. What it shares are a bunch of little spikes. These little spikes, someone decided looked like a crown. And you'll want to remember those spikes for later in the talk. Those spikes are exactly what's responsible for the ability to infect humans. And it's those spikes that are the targets of some of the vaccines being made right now. So coronaviruses. 3 of them, actually now 4 of them, cause the common cold. We don't much care about them. They don't tend to kill anyone. 3 of them are quite a bit nastier. One of the coronaviruses we care about showed up a few years back, and its name was SARS, severe acute respiratory syndrome. Another one showed up shortly after that, and its name is MERS. That particular coronavirus causes the Middle East respiratory syndrome. Both of these coronaviruses are lethal in humans to one extent or another. Another coronavirus showed up in December of 2019. This coronavirus was named SARS-CoV-2. It is a novel virus. This means that nobody on the planet's ever seen it before. No human has ever had the chance to get it and develop immunity to it. And that word novel is among the most eerie for those of us interested in epidemiology, because novel means we don't know. We don't know how to diagnose it. We don't know how to treat it. We don't know how it spreads. We don't know what it signifies for the human race. And that's why novel gets so much attention worldwide. So how was it that all these coronaviruses hanging out in bats became a threat to humans? The way they became a threat was through something called vectors. A vector is a delivery system. Think of it as an Amazon Prime driver. It doesn't really stick around, but the thing that it carries, the package it drops off, may not be of benefit to who's getting the delivery, us. When it comes to the three nastiest coronaviruses, the vectors are different. In SARS, what happened was that in bats, they were able to transmit this particular SARS coronavirus into something called a civet cat. It's a little teeny wild cat, kind of interesting. In MERS, it was a bit different. MERS, being in the Middle East, found its favorite vector in camels. So what does all this have to do with our new coronavirus, SARS-CoV-2? Our new coronavirus decided it was going to infect us in a different way. And that way is currently a question mark, but we do have a couple of possibilities. My favorite possibility at this point is called a pangolin. What's a pangolin? It's the cutest little mini armadillo thing you have ever seen. Honestly, I love this little thing. However, I would advise each one of you not to eat pangolins. It is believed that if a pangolin is the vector for this particular nasty virus, it's human contact with that pangolin, probably in the form of consumption, exposure to wildlife in a way they weren't meant to be exposed, that allowed SARS-CoV-2 to come into humans. When a SARS-CoV-2 virus infects a human, it causes a disease in some people. The disease is called COVID-19. It doesn't actually cause a disease in everybody. In some people, our cells are able to see that SARS-CoV-2 virus and say, yeah, whatever. We knock it down. Our immune systems just squish it. It doesn't have the chance to multiply. Well, if that were the case in all of us, none of us would really care about COVID-19 or SARS-CoV-2. Unfortunately, in a number of us, SARS-CoV-2 is able to cause illness, and in some of us, it's able to cause death. So what's the difference? One of the differences may be in the little receptors that live on our cells. It turns out that SARS-CoV-2 uses a particular doorknob, a receptor, in order to enter our cells. And that receptor in us humans is called ACE2, or angiotensin converting enzyme 2 receptor. Some of you may have heard of ACE because you take a medicine for your blood pressure called ACE inhibitors. Well, those are the same receptors that can be responsible for high blood pressure. They're upregulated, meaning they work a little too aggressively. And in those of us with a lot of these receptors, turns out we are more likely to have high blood pressure, and we're also more likely to get severe COVID-19. But high blood pressure isn't the only thing that can lead us to being more susceptible to severe COVID-19. Being over the age of 50 is one of those that increases our risk. And in fact, about a quarter of the people with COVID-19 serious enough for hospitalization and death are between the ages of 50 and 64. we all know that it's those of us over 65 who are at most at risk of death. But I would say it would be a mistake to dismiss non-lethal COVID. If you've ever been hospitalized, you can understand a bit about what a life-changing event that can be. Personally, I was hospitalized at the end of June for an emergency appendectomy. And although I'm just fine, feeling great, thanks very much, surgeons, and probably more important, the anesthesiologists, the after effects are pretty intensive. Recovery from any illness takes time. For COVID, it can take up to 3 months. For an appendectomy, my main recovery has been nearly $18,000 in hospital bills. And that's as somebody who has private insurance. So I would say that if we dismiss non-lethal COVID as 99% of us will survive, I think we're missing kind of the bigger picture. There is an economic and also a social cost as well. Many of us experience prolonged hospital stays when we have COVID-19. It's a little bit weirder than influenza, for example. We spend weeks in the intensive care rather than just days. That's different. We also spend weeks at home where we're not sick enough to be hospitalized, but we have a hard time catching our breath enough to go to the mailbox. That's really different. That is not your dad's influenza. So I'd like to delve a little bit more into the deep science of COVID-19. COVID-19 is kind of pretty overall. It has these little spike proteins, these little spikes covered in protein. And it also has this wiggly stuff inside called RNA. RNA is one of the flavors of viruses. There are many RNA viruses. Hepatitis is one. RNA viruses have some characteristics that make us as virologists a little nervous. RNA viruses are really unstable. They don't have the same type of proofreading ability that other types of viruses have, such as DNA viruses. If you get injected or exposed to a DNA virus, that DNA virus has to multiply like any others in order to make you sick. And when it multiplies, it's pretty consistent at accurately reproducing itself. RNA viruses really aren't. Without this proofreading ability, they like to do something on a scale much beyond other types of viruses, and coronavirus does this too. They mutate. That means they make errors in transcribing themselves and replicating themselves. So why do we care about mutations? Mutations can be a good thing. They can be cute, like our duck mutant friend. They can make a virus less infectious. They can make a virus unable to transmit to anyone else. Those are all delightful mutations, and many of those certainly happen. But some of the mutations that happen, and one that's happened already with SARS-CoV-2, is a mutation that has made the virus more efficient at transmitting from human to human. Now, before we all freak out, being more transmissible doesn't mean more lethal, and there is no evidence yet that this new mutation is deadlier than the old SARS-CoV-2. I'll show you what that mutation looks like on screen. Again, we're diving into deep science here. This mutation is called the D614G mutation. We believe it happened sometime in February. And as of May 2020, it is the mutation found in 95% of all the COVID specimens tested in the United States. It is the dominant mutation. The mutation happened at the level of the spike protein, and that's why it's infectious. The spike protein is like the key to our cells. That key became a lot more exact, and because of that, it's efficient. So when you talk about a virus that's not any more lethal, you have to think about statistics. If a virus kills 1 out of 100 people and only 100 people get it, it's no more lethal than a virus in which 1,000 people get it and only 10 people die of it. However, you've got 10 deaths instead of just one. And that's a huge difference, and something that has probably changed the trajectory of SARS-CoV-2 and the disease COVID-19 across the United States. We know we're really good at spreading this virus. So how? How do I give you this virus? Well, first of all, I have to be exposed to it. This virus has to be in the environment. One of the things we looked at in the state of California was that there was no early peak. There was no surge in March and April. And so that affected what happened during the shutdowns. If you want to look and say, well, was public policy sensible at that time? You have to apply that public policy in places where you can make a difference. If there's no virus, you can't make a difference either way. Open or shut, the amount of virus isn't there to cause disease. But that changed. And like across many of the places in our country, the surges happened at different times. The virus spread sequentially. It spread based on airplanes flying around the world. It spread based on people getting more comfortable congregating. It spread based on people going to work and being exposed to more copies of that virus. I just saw a question that kind of fascinated me. It's a pure science geek question. How is a mutation identified? Can it be seen on a molecular level? It can be seen on a genetic level. One of the cool things that Chinese scientists did in January 2020 is they identified the actual genetic sequence, the blueprint or code for SARS-CoV-2. They then shared it with the world. It was that point that scientists around the world began racing to get a vaccine. The genetic sequence is not constant, and I'll show you the blueprint of how DNA and RNA decide to hang out. DNA and RNA have a couple of key differences having to do with what's called base pairs. Base pairs just means that blueprint. I'm still struggling with my screen, but I'll try and describe it to you. DNA and RNA have these different components, thymine and uracil. If you change the order in which those pairs of amino acids, that's what uracil and thymine are, if you change those, that's a mutation. And that actually changes how the virus behaves. Does it become easier to get in the cell? Does it become more likely to severely affect the lungs? That would make a viral more lethal, more virulent. So it's those changes that have affected the trajectory of this virus. If we could figure out a way to make this virus horrendously lethal, and I know this is a strange concept, if we could make a mutation and make the virus wipe out close to 90% of the people that it affects, the virus would burn out quickly. Why is that? Well, because it would run out of people food to infect. This happened with a horrifying virus called Ebola. Ebola virus comes in a number of different flavors. One of those flavors is called Ebola Zaire. Ebola Zaire kills more than 90% of the people it infects, and therefore it burns out in a community, wiping out the population so quickly that there's barely any chance for that virus to travel around and infect other communities. Not impossible, but that's one thing we've seen with Ebola Zaire. It doesn't tend to spread widely before it actually kills an individual community. Ebola has some other mutations though, ones we really like. One is called Ebola restin. Ebola restin mutated so that it's able to affect our primate friends, chimpanzees, but it is incapable of infecting humans. And so when Ebola Reston was identified in a laboratory with chimps in it in Reston, Virginia, a lot of us freaked out thinking we've got Ebola in the United States. But it turned out none of the lab workers who were exposed and affected by it became sick. What we're hoping as virologists is that SARS-CoV-2 manages to mutate itself out of existence. It hasn't done so yet. One of the other issues with mutations that's important has to do with vaccine development. If we develop a vaccine that specifically hits the shape of the spike protein right now, what happens if that spike protein on the edge of the COVID, what if that mutates? Our vaccine may not work anymore. And that has been a huge problem in trying to develop other coronavirus vaccines. You'll know that when you go to CVS for your Pneumovax or your influenza vaccine, they're not going to offer you a common cold vaccine. There does not exist one yet. However, there are a number of great strides being made in the vaccine world. I'm happy to share those with you. But what I'd like to do instead is open it up to questions, topics that are of particular interest to you when it comes to this. I'll show again some of the options for topics, but I do like to think on the fly, so feel free if you have other topics not on my list, feel free to ask away. Thanks very much. I'll turn it over to whoever wants to moderate questions.
That would be me. So if you've got a question for Dr. Halderman, if you could raise your virtual hand. I'm going to go by unmuted. So Chris, Leslie Davis, do you have a question?
Yeah, just real quickly. Can you say a few words about viral load and exposure and dose?
Sure. So viral load means how many copies of the virus, what volume of it do I have in me at any one time? And probably more importantly, how many am I shedding every time I cough or sneeze or speak or clear my throat or eat or do anything that releases tiny little particles of saliva? Viral load in SARS-CoV-2 is really weird, and here's why. Let's say you get a cold or influenza and you're really sick. At the time when you're really sick, your viral load is really big, and so you're most infectious to other people at the time when you're really sick. However, what's been measured in severe COVID-19 is that the highest amount of viral load that we deliver to the environment around us is in the incubation period of the virus. The period of time after the virus gets in our cells and is starting to multiply but hasn't done enough to make us sick yet. That's the time, that asymptomatic period of 1 to 14 days after infection, that we actually release the largest amount of viral load. As we get sicker and sicker, particularly intensive care unit, we're releasing fewer copies of the virus. Not few enough not to infect the healthcare workers around us, but certainly fewer copies than in that first period of time before we develop infections. That is a quirk of SARS-CoV-2 that we as doctors are not thrilled about. One of the interesting things about viral load too in COVID-19 is the place that it likes to hit first. Unlike influenza, which likes to do its damage down in the lungs, SARS-CoV-2 likes to start out in our nose and in our upper throat. Those are the cells with the highest numbers of these ACE2 receptors. And those are the cells that it's really happiest to make itself replicate in first. Think about every time you cough or every time you clear your throat. You're generally not coughing up the bottom of your lungs. You are in fact releasing the little bits of saliva living in your nose and in the back of your throat. Since that's the case, before you know you're sick, that's the time when you're releasing the most viral particles. The other weird thing about that is something called anosmia. Anosmia was something noticed primarily by nurses. What anosmia is the sudden, out of nowhere loss of the sense of smell. What a strange thing. The first symptoms of SARS-CoV-2, of COVID-19, loss of sense of smell, loss of sense of taste, and that's been found in more than 60% of the people in early COVID-19 before they appear sick. So, strange virus. Other questions?
Skip McCown, you're up.
Thank you. How confident are we that we're going to have a vaccine for COVID-19 when we still don't have a vaccine for AIDS?
Sure. Confidence is different depending on whom you ask. Initially, my confidence was quite low. I'm pretty skeptical when it comes to coronaviruses and vaccines. But I've seen something that I've never seen in 30 years in healthcare. And this is what I've seen. There are currently more than 150 vaccine candidates in the pipeline. 7 of them are in the latest clinical trials. To have done this in 8 months is almost impossible. I have a hard time imagining it as somebody who's done some laboratory bench work. What's been found is that there are different targets and different ways of giving us vaccines that may be helpful in this particular vaccine search. One of the coolest things I've seen is a new vaccine technology called messenger RNA, and it only should work on RNA viruses like coronavirus. Messenger RNA vaccines are in development by a couple of companies, one of which is Moderna out of Massachusetts. Messenger RNA vaccines are based on this idea that if you can introduce a blueprint for a virus into a human, the immune response of the human will build up a bunch of ammunition and killers, cells that will destroy anything that in the future shows up and looks like this set of blueprints. But what if the blueprints are for a virus that can't do what SARS-CoV-2 can do? It just looks like it. What if it's a blueprint for a house with no doors and windows? When the body builds this blueprint house, this defective house, it doesn't make you sick. It just makes you able to view in the future anything that looks like that house, including SARS-CoV-2. So, although I live close enough to Las Vegas, I am not willing to place any bets on vaccine development. I will say that the efforts have been beyond what any disease efforts have been in the past, including HIV. Remember, in HIV, and that was a pandemic during which I also served in the 1980s, it was 5 years before we identified the sequence, the actual virus that caused HIV. So I would say we're on fast forward, but I'll hold my cards close to the vest. Next question.
David Wall.
So for those who get this on a severe level and have ongoing implications, is the virus, the little crowny virus, is that still in their bloodstream? How long does that stay in their bloodstream? Well, that's actually one of my questions, but we'll start with that one.
Sure. Well, the virus itself uses that protein coat to inject its guts into the human, and then it takes over. It's like a little factory hijacker. That RNA, that genetic material inside, is what causes the problem. It's not the protein coats on the outside. So if you're looking at a test for COVID-19, you're going to want to look at a couple of things. A test for that actual guts of the virus, or a test for the antibodies that our body makes in response to the virus. You don't do a test just for the little spiky protein coats. Those things are just carrier pigeons. They're not what caused the disease.
well, then more specifically, then my question isn't regarding that. You know, I phrased it wrong. So somebody catches this, and 3-4 months later they're still having severe symptoms. Is that what is still inside of them, or did the virus infect what it needed to infect and then leave their body, but now they're just having the aftermath?
Sure. In the acute period where you're truly really sick, you're not even getting a little better yet, you're still shedding virus. And in fact, there is viral DNA inside you. The after effects, the 6 to 8 weeks effect, where you can't get out of bed, like my young, healthy doctor, after 8 weeks, who still couldn't go back to work, he was that ill. What you're dealing with is the damage that was done by the virus and the amount of energy that it takes in the body to deal with that damage, to recover, to repair your lung cells, to repair the blood vessels that have been damaged by SARS-CoV-2, to repair the lack of oxygen that affected so many of the cells in our body. It's that repair period in which you're not infectious, but you are just awful, not yourself yet. That's the after effects, not the actual virus. You would probably, in most cases, test completely negative for active virus at that point.
Okay, so quick housekeeping. So there are 4 people in the queue right now: Pat, Thomas, Fred, and Rich. For those of you who don't know how to raise your hand, unmute yourself, and I will take note of you and put you in the queue. So Pat Flaherty, you're up.
Doctor, is there some type of a supplement or supplements over the counter that we might use to help stave off or build our resistance to not getting it or not getting it as severe?
Sure. I will tell you that, first of all, the best answer is we don't know yet. The second best answer is there are some things that appear on a doctor clinical level to be making a difference in patients in the hospital with COVID-19. And those studies, which aren't big enough to say this is the right thing to do show some supplements that are harmless and that may help. The supplements in particular, vitamin C, that appears to make a difference either in our response to the virus or in our body's ability to avoid severe damage from the virus. The other one that appears to be helpful, that may or may not be, but is largely harmless, is vitamin D. It's really difficult to overdose on vitamin D. I have multiple sclerosis, and my doctor has me on 10,000 units of vitamin D daily. That's been shown to decrease multiple sclerosis relapses. It's entirely harmless at that dose. So if you want to roll the dice and you don't have other things that would make you unsafe to take those 2 supplements, those may be helpful. But again, nobody's got the real answer quite yet.
Was zinc helpful?
Zinc is thought to stabilize some of the membranes of the cells from being infected. And that is one that is very, very commonly in use. It's mostly harmless, and it also may be helpful. Thank you for reminding me of that one. Zinc also has an interesting effect that makes us feel better with colds. It kind of dries up the mucous membranes in the nose and upper throat where we get annoyed by irritation. So it may be helpful in that respect as well.
Thank you.
All depends on.
Thomas?
Yes, sense of smell and loss of taste seems to be one of the first things that shows up. How long can one expect that to last if one feels recovered?
Some of the people who've gotten it early, such as in the spring, have not recovered their sense. Some have reported between 4 and 8 weeks. It's so different depending on the individual. If you get not as sick with COVID-19, it tends to resolve more quickly. If you get hospitalized or need intensive care unit, the effects tend to last longer, including this anosmia, lack of sense of smell.
Thank you.
Fred Stambach? Unmute yourself, Fred.
Thanks, sorry. Dr. Halderman, can you offer some clarity on the issue of transmissibility of the virus out of doors? You see people walking around on park pathways with masks on, and I thought the CDC said pretty early on that out of doors, when you're passing people casually on a pathway, that the risk of transmissibility is really low, but we seem to be getting mixed messages about that from hospital and medical authorities.
Sure, great question. So this issue of 6 feet of social distancing, let me tell you where that comes from. If you are sitting in a room 6 feet from someone, there is no circulating air, so no fans, no air conditioning, and your mouth is closed. You're not speaking, you're not singing, you're not clearing your throat. The particles that you would release from your nose and mouth, tiny little bits of saliva, so small you can't see them, are so minimal that they're not going to travel that 6 feet. If you change the environment to one where people are walking around, stirring up the air conditioning, or singing or speaking or eating, doing things that will cause a little bit further spread, and then you get these particles of saliva that can move even further around and float around as they dehydrate. They actually float around and stick around more often, and someone else can walk into that cloud of virus. That's still transmissible. When you're outdoors, you have a lot more ventilation and a lot more ability to circulate that air and to ventilate it out. It doesn't mean there's zero chance of transmitting it to someone outdoors. If you're outdoors in close proximity to someone who gives you a direct hit with a sneeze, the viral exposure is going to be higher than someone who just passes you on a trail, but it's not zero. If we're outdoors on a trail and occasionally passing by someone, the risk is lower. Like I said, it's not zero. And so what I've seen on trails in California is that people will have a mask with them, a face covering, cloth of any type, anything that'll block spit, nothing magical, no N95 respirators, anything that'll block spit. As they're passing each other in close enough proximity, they'll throw the masks on. That being said, if you're in a parking lot going to your grocery store and you see someone who's wearing their mask outside and gets in their car and still has their mask on, either they misunderstand how they're used, or like me, they forget they have it on. Like a lot of healthcare folks, I've been wearing masks at work for many hours a day to the point where it doesn't seem like a thing to me anymore and I forget I have it on. Other people are so irritated by it that they have to rip it off as soon as they're out of a place that requires it. And I understand that. It's like uncomfortable underwear. Eventually you'll get used to it, but you really don't like it at first.
Rich?
Yes, wanted to follow up a little bit on the research end and the vaccine development end. You talked about how fast this track has been moving. How much of that is due to the increased availability and sophistication of computer modeling?
A lot of it has been because of the complexity of RNA genetic sequences. Computers are an incredibly valuable tool. These were not available in the early attempts at sequencing HIV. So along with things like electron microscopes, computer modeling has been incredibly helpful. And that's the reason we know the names of these little mutations, like the D mutation I was telling you about. Specifically, it's because of computers. Computers do something else. They allow us to very easily share scientific knowledge lab to lab, country to country. And that's been a huge benefit. It was researchers in China who first gave us the sequence. I do have criticisms for the government in that nation, but I'll reserve those criticisms for those who take actions such as the government has done, not for the actions of the people sitting behind microscopes trying to save their fellow citizens' lives.
Okay. Mike Edwards?
Yes, you've mentioned how many
vaccines are being worked on at one time, are most of the researchers working in cooperation and sharing information and discoveries, or is there a lot of independence? I mean, is this a whole team effort, or is it first one wins?
Yes and no. Okay, so we look at an American company, Pfizer, and then we look at a German company, BioNTech. Those guys are working together. They're one of the messenger RNA vaccines. Then we look at Oxford University and AstraZeneca, an entirely different private company, not related to the university. They're working together. So a lot of the information is shared. However, particularly in the private companies, this information is proprietary and valuable, and a lot of it is withheld. Some of the cases, the withholding is not particularly helpful. One of the places where viral information has been withheld, and vaccine information in particular, has been in the development of the Russian vaccine. They have been incredibly tight-lipped about what they're doing with this particular attempt. I'm looking for the name of that. Yeah, I don't have it in front of me. All we know really is that the Russians have tested this vaccine in 37 people. That's it. And they approved it. So does it work? How would we know? 37 doesn't give us information. Can we see the data? Nope. So I don't know is the answer on that one.
Okay, thank you.
Jamie?
Hi, Dr. Halderman. Thanks for speaking with us today. I was wondering if I'm going to pivot slightly and ask you about your professional path. It's sort of an unusual transition to go from surgeon to virologist. Could you just talk about who you're working with currently and how you find yourself in this new role?
Thanks. I'm an amateur. I'm a pure amateur virologist of necessity. The transition for me, my last operation was in April of 2016. And what I was noticing was that I had strange symptoms in my feet and in my hands, numbness and tingling. And so I went to a friendly neurologist who said after about 7 months, you have multiple sclerosis. And so that ended the surgery career part of my practice. After a little bit, I did some consulting, medical board kind of stuff, but I found that my deep passion, my love was in doing surgery. And so that was over for me. United States is a little interesting. If you're subspecialized and board certified in one area of medicine, you're not particularly allowed to practice in other parts. So with the limitations that I have with MS, I'm not able to go back and do a completely new residency. And in terms of working full-time with the demands of surgery and the limitations of MS, it's not realistic. So that's how I became an armchair virologist.
Conrad?
Yes, Dr. Halderman, what is the medical explanation for why the United States has 25% of the world's cases and a country like Norway, where we have good friends, has minimal number of cases as a percentage of the population?
Okay, a couple of things. I am not a huge fan of using case numbers. Case numbers are so dependent on a number of things. Number one, do you have the resources to do large numbers of tests? Can you reach enough people, let's say sub-Saharan Africa, to even find out what the COVID numbers are there? Number two, the sensitivity of the tests varies greatly. There are almost 200 different types of COVID-19 tests on the market right now, and some of them have a horrible false negative rate, and some of them have a fairly high false positive rate. So it is a problem if you're just looking at case numbers. The numbers during an active pandemic I think are more helpful to look at are the number of deaths per 100,000 population. When you look at countries like Norway, they do tend to have lower numbers. When you look at their neighbors, Sweden and Belgium, those are some of the highest rates of deaths per 100,000 people. If you compare the United States in terms of mortality, you can't say that we're homogenous. If you try to compare Montana to the rest of the world, Montana beat COVID-19. The number of deaths per 100,000 is lower than any typical influenza year. But don't try that with New Jersey or Connecticut. And currently don't try that with Arizona, Florida, or Nevada. So I'd say that it's really apples and oranges to try to compare a country where the resources tend to go toward malaria treatment and clean water and prevention of parasites, as opposed to COVID-19. You look at a country like Burkina Faso, which is one of the most dense populations in the world, they report almost no cases, almost no deaths. I have a hard time thinking that that's quite as reliable as what I'm hearing out of Austin, Texas.
Thank you, Doctor.
Sure.
Grace?
Good morning, Dr. Halderman. Mine is just a practical question. You know, there's very little as private citizens that we can do. One of the things is wearing a mask. And so perhaps you could give us an update on the best science behind masks, like is the front of it contaminated when you take it off? How do you handle it? How do you decontaminate it? Do you need to decontaminate it? Do you need to change it every so often? Best fabrics or materials and that we can get our hands on.
Sure, thanks. I was wondering when the mask question was going to come up. There's nothing more popular on Facebook. I get 3 to 5 videos per day about masks. Let's take a step back and just think about what we're doing when we cover our faces. Why do we use a Kleenex? Because we don't want to have stuff come out in the environment. It's kind of icky. Well, that's really all we're doing with a cloth face covering. It doesn't have to be complicated. It certainly could be adorable, such as my Golden Knights, soon to be Stanley Cup champions team mask. But it could be as simple as a bandana or a really adorable silk scarf folded over a bunch of times and covering my nose and mouth. Essentially what I want to do is cover any part of me that could release tiny bits of saliva, respiratory secretions that come out every time I speak or sing or cough. If I have very open weave fabrics with a really low thread count and it looks kind of like that, of course my spit's going to get through those little openings. Don't crochet a mask, please. If you've got something complicated like a 7-layer vacuum cleaner filter, well, that's great. That's going to prevent all your saliva. It's also going to make it impossible to breathe, so you might not want to do that. Putting a covering on should not be an ultra complex issue. It does not have to function as a submicron filtration. It is not personal protective equipment, though it will block some viral particles from reaching the person wearing it. That is not its primary function. When I go into a patient room, I'm wearing a very different type of face covering. In fact, it's a respirator. So I'd say the arguments about, well, wearing a piece of cloth and preventing virus is like trying to prevent flies from getting through a chain link fence. Well, that's not an apt analogy. We don't care about the flies getting in. We care about the soccer balls inside not getting out. And that's how we decrease community spread, decreasing the amount of saliva we transfer to the environment that could potentially, in someone who doesn't know it, contain SARS-CoV-2. Does that answer your question enough about this issue? Probably not.
Okay, we have time for 2 more questions. It'll be David Wall first and then Jamie Texter, and then we'll wrap. So David, go ahead.
So there have been a few different articles on different blood types that may be more susceptible to getting this. And I don't know if if there's any fact behind the articles or not. And in particular, they say A positive might be one of the blood types that's more susceptible. Is there any basis to this, or are they just people trying to write articles?
There's theory. There's certainly theory, and it has to do with the penetration of the virus into cells and ACE2 receptors and who has more of them. Some with A might have more of them than type O. Some with type O might have more of an immune response because if you have type O, you have to reject everything that looks foreign. Whereas if you have type A, you're kind of able to allow things that sort of look like the type A antigen. And so maybe you're a little more permissive, but all of this is theory. This is not something that has practical use quite yet.
Great. And last, Jamie?
Hi again, one more question. I just saw an article in The Atlantic 2 weeks ago, maybe 1 week ago, about the E25 saliva test strip and this sort of paradigm shift idea that is being proposed for testing of you every day, every person every day before they enter any public space, and trying to shift our approach. And of course, these tests are not perfect. They're less perfect than some of the others, but we get the response that moment within 15 minutes. We make a decision about entry into a public space with other people as a result of that test. Do you have it? Can you speak to that one at all? It's from E25
Sure.
Bioscience in Cambridge, and I just wondered about the whole concept, what your thoughts are about that idea.
Sure, I've heard that there's one with a preliminary approval. The problem that we're dealing with when we come to tests like that are easy and convenient and cheaper and more tolerable to people is that there's always a trade-off, and the trade-off is in how accurate they are. So we do know that when we have tests like that, they're going to be a lot less able to find the virus because there's a higher load of virus in the posterior pharynx, that's the back of the nose part with those swabs that hits. There's less virus in the front of the tongue with the saliva. So we are losing some of that. We also know that test strips do not sample as much volume of the person to look for virus particles. And so by nature, they tend to be less useful. However, more of us are willing to get a little dipstick in our mouth every day than we are one of those swab things in the back of the nose. So it's like this. What I think would be a shame is to change behavior based on what might be an inaccurate test. If we have a false sense of reassurance that the dipstick said, I don't have it, so I must not have it. Well, that may not be a good idea. We can still have it, it's just the test happened to have missed it. And that, by the way, is true of even those horrendous nasal swab tests.
So obviously we'd prefer this test be more sensitive than specific. Do you have any feeling for numbers that would be acceptable to provide a screening, just a screening threshold type approach where we're gonna tolerate some false positives because it still means the person got sent home, but we can't tolerate false negatives, right? So do you have any, is there any established, like, I know it's impossible to say, but ballparking, like, is there a number? Is that 85%? What, any numbers? What do you guys think?
Unfortunately, in current testing, particularly in tests we have for other diseases right now, we mandate a sensitivity and specificity that exceeds 98.5%. Otherwise, when you're looking at big populations, the volume of people that you're missing who do have the disease or that you're incorrectly diagnosing who don't have it gets to be so astronomical. There is no COVID-19 test on the market out of all the 200 plus that hits that level of sensitivity and specificity. Some of the best ones right now miss about 15% of positive people. So I think it'd be a mistake to act like you don't have it just because one test says, I don't have it. And in fact, in the hospital, tests are repeated 3 to 5 and more times because of that issue with the testing. These tests are brand new. We can't expect them to be perfect quite yet.
Thanks.
Conrad, back to you.
Dr. Halderman, thank you immensely for this really timely topic. All of us have questions about these issues, and you have done a stellar job of explaining this to us. As a token of our appreciation, we are going to, you'll see the certificate here, and on the right side, you'll see the prosthetic device called an LN4 hand, which is developed by a Rotarian, is installed on people who have a stub remaining on an arm, and they then can have a hand that will allow them to do things that they were unable to do simply with a stub. One of these will be given to a person in the world. We don't know them, you don't know them, but we are participating in groups that fund these, and we hope that you appreciate this. And again, thank you really a lot. It took me back to Dr. Harden 55 years ago at UCSB, talking about ribonucleic acid and deoxyribonucleic acid when it was only a couple of years old in terms of the discovery. So I enjoyed that. Thank you
very much. And I want to tell you all, I'm particularly touched by that gift as someone for whom hand function and lack of function has made such a huge impact in my own life. I can't think of a more touching gift on my behalf. So thank you.